Well, welcome everyone to NAMI at noon. I'm Amy Brundle. I'm the Director of Marketing and Communications at NAMI North Carolina, and we're so pleased to have everyone here for today's webinar. First of all, as always, we'd like to thank the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services for their support of today's webinar. Just a couple of housekeeping items. If you've been with us before, you know this, but for anybody who might be new today, if you've got any questions for today's speakers, please put them in the Q&A section down at the bottom of your screen or in the chat box, and we will answer them towards the end as time allows. We will also be sending out any further materials that the speakers provide later on in the week. And now, without any further ado, I'd like to introduce today's speakers. Simone Seitz is an experienced professional with a background in nonprofit leadership, education, and small business, including expertise in project, marketing, and event management. Her lived experience with eating disorders gives her a unique understanding of the challenges individuals face, and that insight drives her work as the executive director of the Carolina Resource Center for Eating Disorders. CRC for ED is North Carolina's only nonprofit providing education, resources, and support to individuals, families, and professionals concerned with disordered eating and recovery from eating disorders. And then Sara Hofmeier is the owner of True North Wellness and has worked in a variety of roles and settings within the mental health field, holding both direct care and leadership roles. She currently provides therapy for individuals and families through her practice. Clinically, Sara has an expertise in the field of eating disorders and is focused extensively on treating patients and their families in both outpatient and higher levels of care, as well as on training and supervising other clinicians in this work. Both of these ladies are extremely knowledgeable about our topic today, and we're extremely glad to have them. Welcome, Simone and Sara, to you both.
Thank you so much for having us.
Let's get our screens doing what they're supposed to do. All right. Do we have the screen doing what it's supposed to do, Simone?
I see it. It's up.
Love it. Excellent. Text box
Phase one,
number
it's up.
checked.
Okay.
All right.
Yeah. Can we scroll to the next one?
Yep.
Thank you.
We're all set.
All right. So we are excited to be with you today during Eating Disorders Awareness Week. I'm very grateful to NAMI North Carolina for collaborating with us and for Amy for her hard work getting everything set up for NAMI at noon. Today, what we're going to talk about is we're going to identify disordered eating and eating disorders. We're going to understand the relationship between DE and ED and mental health, and we're going to gain a little bit of insight into nutrition therapy for DE and ED. And then we're going to explore some treatment information and receive resource and referral information. And again, if you have questions throughout, if you'll put it in the chat, we'll try to keep our eye on it, but we're hoping to end about 10 minutes before 1 to give plenty of time for Q&A. So what are eating disorders? They are real life-threatening illnesses with potentially fatal consequences. They involve extreme emotions, attitudes, and behaviors surrounding food, movement, and body image. It is not just about the food, it's about food, movement, and body image. And it's caused by a range of biological, psychological, and sociocultural factors. I always like to start with the 9 truths about eating disorders because we are still busting these myths. Truth number 1, many people with eating disorders look healthy yet may be extremely ill. And you're probably going to hear us say a few times through this presentation that you cannot tell from when you're looking at someone whether or not they're struggling with an eating disorder. Truth number 2, families are not to blame and can be the patients and providers' best allies in treatment. For a long time, a lot of people blamed the families, and actually we need the families. They're the biggest advocate. And while there may be some environmental factors that come into play that do include the family, they are certainly not to blame for an eating disorder. Truth number 3, an eating disorder diagnosis is a health crisis that disrupts personal and family functioning. It involves the whole family. It impacts the whole family. Truth number 4, eating disorders are not choices, but serious biologically influenced mental health illnesses. And again, for a long time, people would think perhaps that it's the female, teenage, white, affluent girl I said female already, that struggle with anorexia, and that's it. That's eating disorders. You're going to learn today there's a lot more to it, and that again, it's not an eating disorder. I mean, it's not a choice. I'm so sorry. Truth number five, eating disorders affect people of all genders, ages, races, ethnicities, body shapes and weights, sexual orientations, and socioeconomic statuses. Number six, they carry an increased risk for both suicide and medical complications. Seven, genes and environment play an important role in the development of eating disorders. There's a 50 to 80% genetic predisposition for someone who is going to develop an eating disorder. But truth number eight, they don't alone predict who will develop an eating disorder. And the last one, which I really want to emphasize, is that full recovery is possible. Early detection and intervention are very important, which is why we love getting on the front end, doing education for awareness, and helping folks not develop the eating disorder. While we're here to support them when they do develop an eating disorder, our goal is to get on the front end.
Thanks, Simone. So, as Simone kind of started hinting at, the cause of an eating disorder is so complex, right? There are so many factors that go into why somebody might end up struggling with an eating disorder. We talked about genes and environment both being involved, but no single thing causing it. So, we think of eating disorders through a biopsychosocial lens. There are certainly biological factors that come into play when we think about somebody's risk. That looks like history of dieting, genetic predisposition, family history, those things all matter. But psychological factors are important too. So history of low self-esteem, feelings of inadequacy, struggling with depression or anxiety, fear, loneliness, other mental health conditions. Perhaps some of the personality traits, right? Maybe having more obsessive thinking, some rigidity, harm avoidance. But then there's also social factors. We know there are cultural norms and ideals that overvalue appearance. We could give a whole separate talk on that today. Family history comes into play as far as kind of what family messages that you might grow up in. Historical trauma, things that people experience in their life, experiences like weight stigma and bullying. So all of these things are important when we think about how somebody ends up with an eating disorder. It's always important for me to emphasize, and I talk about this in my family work, especially with folks, there is no one single thing. There is no one single thing that we can go back and say, that caused it. And so often in our work, we don't spend a ton of time trying to find the thing that caused it, but we want to understand how all these factors are at play for somebody because they're the things we'll need to address to help interrupt what maintains it. And so I think it's really important to embrace kind of how multifactorial eating disorders are in terms of what ultimately gets me to the point of struggling. We also want to talk about disordered eating versus eating disorder. They're both terms that get thrown around, and they're terms that can be really confusing for people when you try to figure out what am I actually dealing with. So a lot of us are familiar with kind of the more, I'll say, stereotypical eating disorders, anorexia, bulimia, binge eating disorder, things folks have some concepts and ideas about. It is important to be aware of what typical signs and symptoms of an eating disorder might be, and we're going to talk about some. We want to really make sure folks embrace the idea of a spectrum of behaviors around eating, dieting, disordered eating that can all be part of maladaptive behaviors, whether or not they are officially diagnosed. Disordered eating and eating disorder symptoms can overlap. They can manifest at different times in different ways for people. And we don't want to ever risk somebody not getting help because we say, oh, well, that's not an eating disorder. It's not serious enough. So there's a whole spectrum of potentially unhealthy or unhelpful behaviors around food and bodies that we want to give equal credit to allow people to receive help. As Simone already hinted at, and we'll talk more about, you can't tell if somebody has an eating disorder by looking at them. They don't discriminate. They comes in all shapes and sizes. And so again, we want to really look at the spectrum of ways that people might have an impact in their daily life and an impairment based on their relationship with food and their body.
I'm just going to jump in quickly and
Go for it.
say a little tidbit I like to say is when we're trying to discern between what is disordered eating and a full-blown eating disorder is we'll look at the intention behind the behavior and then how extreme the behavior is and how much it impacts the quality of life or the day-to-day. So a lot of times people ask me, how do I know? How do I know? And I say, let's look at that. What is the intention behind it and how much is it getting in the way of life? And that's a good pointer to just think about.
Yeah, that impairment piece is huge, right? Being able to really look at what's getting impacted, what's changing as a result of this. When we think about some of the things that lead up to disordered eating and eating disorders, we know that dieting is a huge predictor or precursor for eating disorder development. Roughly 45 million Americans go on a diet every year, and we know that most, if not all, diets fail, and individuals end up regaining a lot of the weight they lose from diets within the 1 to 5 years after completing their diet. 35% of folks who go on a diet end up dieting on a regular basis. And of those regular dieters, 20 to 25% of individuals go on to develop an eating disorder. When we talk to folks who struggle with eating disorders, 59% of those who are in treatment consider prolonged dieting as one of the precipitating events to the onset of their eating disorder. So it's really important to highlight kind of the significance of that dieting behavior at setting off many of the other factors that can pave the way for eating disorder development. And for us, they often are a red flag behavior that we look at when we kind of take eating histories and really look at what's going on for somebody.
Sarah, would you mind briefly touching on why people gain their weight back?
Yeah, so when we think about kind of what happens during a dieting phase, right? Most people are ending up restricting what their body needs. They're not getting enough of the nutrients that their body needs to function at its best. And when you stop the diet, and re-engage potentially more normative eating or potentially more binge eating or other behaviors that can come after a period of deprivation, your body is going to respond differently. And so bodies are getting back to kind of wanting to have all of the caloric energy that they didn't have before and being able to try and make up for that period of time they were in deficit. And then individuals who had been dieting may have lost touch with some of their hunger cues and fullness cues and aren't as able to regulate their eating in a way that matches with their needs. And so the body goes through this period of massive fluctuation, both in terms of how it's using energy and likely the energy that it's getting. And so it becomes hard for our bodies to trust the process of regular intake, and it responds in an equally unpredictable way. All right, when we think about diet culture, like I said, we could do a whole talk on this. So I'll try to do these 5 points in like real short time. But diet culture, this idea that in our society that we should be dieting and should be changing our body are incredibly harmful beliefs for those who go on to develop eating disorders. So first of all, we know, just like we said, diets don't work. They're associated with greater weight gain and increased rates of binge eating later. We also know dieting is really dangerous. It can be a setup, like we just said, for losing touch with your appetite, following rigid food schedules, following rules, and can lead to eating disordered behavior due to that inability to trust your own nutritional needs. We also know there's nothing good about deprivation, right? Focusing solely on dieting takes away our ability to think of foods in a more holistic way and creates this good-bad mentality that perpetuates further negative ideas around ourselves. We also know that fat does not equal unhealthy. Healthy bodies come in a range of sizes and shapes, and weight stigma that goes along with diet culture poses even greater threats to psychological and physical health. And then lastly, we want to reject diet culture to fight back, right? We and everybody around us deserve to live a life that is full and free of the pressures of diet culture. We don't want to engage in practices that encourage self-hate. And so when we push back on diet culture, everybody wins in terms of creating newly acceptable ideals in society. And the last piece I'm going to touch on real fast before tossing it back to Simone is this idea of fat phobia. And we don't have time to go into all of this today because we have so much we want to cover, but I would encourage everybody to take a second and click on this tool if you haven't already to do a little bit of your own assessment around where you might experience weight bias. When I think about kind of where this shows up for people, particularly clinicians or those in healthcare, it's often a very sneaky bias that many people don't know that they hold. And fat phobia or weight bias can show up in the way that we provide care to people. It can show up in the ways that we identify problems, right? We talked about eating disorders coming in all shapes and sizes, but it's all too common for somebody to look at an individual in a larger body and hear very disordered behaviors described and tell them they're fine. Right? Because we have lots of beliefs around body sizes that can be really harmful. So taking a minute to check in with yourself on this, to recognize where you might hold weight bias that you might not be aware of, gives you a chance to then start to look at how does that impact my practice? How does that impact how I interact with people? And where do I maybe want to work on some changes to help ensure that I'm giving everybody equal access to care and support and treatment that they might need?
And I'll just touch on that to say, even though I know, Sarah, I'll speak for you too, even though we're in this field and I have lived experience, when I took that self-assessment, I didn't even realize how much bias was still living in me. So there's no shame about it. It's really just saying, oh, wow, like this is something I think, and let me check on that. So there's no like, you're wrong. It's more like just, hey, some awareness. With this slide, we have a medical provider resource, and I highly encourage all of you taking a look at this. We named it Medical Provider Resource because originally it was developed because we knew that healthcare providers don't really get a lot of training on eating disorders. Actually, most physicians get about 30 minutes. And I found myself saying the same thing over and over. So we pulled together a group of folks and we developed this resource. But the resource is really appropriate for everyone. It's kind of like I call it the Cliff Notes of eating disorders. Again, what are the signs and symptoms, which we'll get into that a little bit, but I'm going to encourage you to use that document instead of me going through every single one. What's the language that we use? What does a treatment team look like? What are levels of care? How do we feel or frame BMI or taking weight? There's just everything that you might want to know when you start having curiosity around eating disorders. And I also encourage you, if you don't mind, is printing it and bringing it to your physician. So we help really educate these physicians, which are usually first point of contact, and they don't really know what to do. So that's that slide. And so some warning signs and symptoms. Again, I'm not going to read this to you. We have this on our website. We have it on the medical provider resource. And then also I linked at the very top of the chat. We wrote a blog for NAMI for Eating Disorders Awareness Week, and there are some included in there. And again, that's another great resource. But some common signs and symptoms that you might see in any of the eating disorders that present: eating alone, a lot of shame and guilt, disgust and embarrassment, thinking about food all of the time, and not being able to disengage and engage with life. Difficulty concentrating and sleep disturbance when we're malnourished. Our body reacts in various ways, and this is one of them. Withdrawal from normal activities and routines. We'll go to the next slide. And here are some that are specific to individual eating disorders. So, for instance, with binge eating disorder, there may be a lack of control around food. Eating until uncomfortably full. That doesn't mean if we eat a big dinner at Thanksgiving, we have binge eating disorder. We all eat sometimes past fullness. So please don't take that and say, oh, I've been binging. I will say usually when there's a binge involved, there's like a disconnect. And the behavior can become a little rote. And then on the other side, you're kind of like, wow, what did I just do? So please don't misinterpret that eating past fullness means you have a binge eating disorder. With binge eating disorder, we might find folks hiding and hoarding their food. And a lot of times people binge because they've restricted. So it's really just that, if you're not eating enough, your body's going to be hungry, and then it may turn into a binge. Anorexia, we're going to see a lot of obsession and rigidity around food, weight, shape, size, calories, dieting. All of these things become consuming, restricting calories, denial of hunger or weight loss, and a lot of times not thinking that the problem is bad enough. And we find that a lot with anorexia. With bulimia, consuming large amounts of food in a short period of time. With bulimia, though, unlike with binge eating disorder, we're going to see some compensatory behaviors, which can include laxative use, diuretic use, excessive exercise, anything to make the food go away. And there's chewing and spitting, that sort of thing. And there's a fear of gaining weight with bulimia. A couple that I really want to emphasize, and I think Sarah's going to dig into this a little bit more. But a lot of people know about anorexia, bulimia, and binge eating disorder, but not a lot of people know about ARFID, avoidant restrictive food intake disorder, and then the catch-all, OSFED, which is kind of where everything else lands that doesn't have a neat little category. The reason that we will spend a little bit more time with ARFID and OSFED is because this is where we might lose folks in the cracks. And I'm probably not, I'll wait for you, Sarah, to dig into this. But ARFID, I will say there's a sensory element to it, maybe not liking the mouthfeel or the texture of the food or the smell of the food. And it's not really driven by a desire to change the shape of the body. Most folks with ARFID actually don't want to be losing weight. They just have a limited amount of foods that they're comfortable eating. OSFED, I am going to leave for Sarah, so we'll just skip that one.
Excellent.
And then, of course, there are a lot of physical signs and symptoms. I do say, go to our website, use the NPR to look at that. But definitely there are things that, oral and GI based, that really just taking a look at some of the things that you can physically see with someone who's struggling with an eating disorder.
All right, so I'm going to walk through some of the diagnoses. This is not full-on diagnosis 101, but I want to go through, like Simone said, some of the things that folks might be a little less familiar with. These are what I think of as kind of the five main buckets of diagnosis for eating disorders that are kind of seen in clinical settings. We know that eating disorders are complex. We know that there are lots of ways eating disorders and disordered eating present that don't align perfectly with all of the diagnostic criteria. And we will continue to underscore that all forms of disordered eating and eating disorders deserve to be taken seriously, and folks deserve to be referred to and connected to help and support, regardless of what box they fit in. So we'll go into the diagnoses, but my caveat is always, if somebody is disturbed or distressed or upset by what they're experiencing, or they're having impacts and impairments in their life, let's get them help and not worry about fitting into a box. And now we'll talk about the boxes. So the three that folks are most familiar with, like Simone already alluded to, we know about anorexia nervosa. Most people have heard of this diagnosis. This is a diagnostic presentation that's characterized often by kind of self-starvation or significant limitations around the nutritional intake that they have, as well as some form of excessive weight loss, right? So that combination of restricted intake and associated weight loss are kind of the hallmark features of this diagnosis. Bulimia nervosa would be the second diagnosis that most people are pretty familiar with. This is characterized by binge eating with a behavior that follows it. So some sort of compensatory behavior, a behavior that is designed to undo the effects of eating. Most stereotypically self-induced vomiting, but this could look like other things like ingesting substances to counteract eating, excessive exercise, other behaviors that are very clearly engaged in with the intention of counteracting the binge eating episode. And then we have binge eating disorder. This is characterized by binge eating episodes, but without an intentional behavior to counteract the binge eating episode itself. Binge eating episode is different from overeating. This is an episode of eating that feels out of control, that feels uncharacteristic compared to other episodes of eating they might have. It feels distressing and feels like something that individuals need support to be able to change. I want to spend a little bit of time on ARFID, or avoidant restrictive food intake disorder, because this is one that folks might not have heard about as much. So ARFID is characterized by a lack of interest in food, fears of negative consequences related to eating, or selective picky eating, all in this bubble of not eating enough or not having enough variety. There are three main types, right? Those three characteristics that we just talked about. It could be a sensory sensitivity, right? Somebody who experiences strong reactions with how they experience the act of eating that makes it unpleasant and hard to either diversify or engage in sufficiently. There may be just a lack of interest in food. They don't experience hunger and fullness maybe as acutely to trigger eating in the same way. They may just not think about eating. They may not have favorite foods. It's just not a thing that perks the same level of interest as other people might have. And then the last is this fear of aversive consequences. That could look like a fear of choking, a fear of getting sick, a fear of, what if I just don't like it and I can't deal with what that feels like to not like it, right? The idea of eating in and of itself has some feared outcome attached to it. So when we think again about ARFID, these are the kinds of descriptions that folks will have around what it feels like to eat, or what it feels like to watch their child eat or try to engage with foods or different foods. The other things we often experience with ARFID is that the individuals have experienced a failure to grow as expected. So it might be a kiddo who has been a picky eater. They haven't eaten enough, and all of a sudden they're falling off their growth chart. They're not gaining weight as expected, which flags that, gosh, maybe there's something about their eating we need to look into more. It may be that they're really dependent on nutritional supplements or some other way of maintaining their nutrition due to a lack of oral food intake. And we might also just see psychosocial impairments. Maybe they're growing just fine, medically they're just fine, but the level of their restricted intake is so significant, they can't go to birthday parties. They can't find anything to eat at friends' houses. Maybe you can't go to work dinners because it's too hard to imagine eating something outside of what feels safe and comfortable to you. As Simone said, this is not driven by a desire to lose weight. This is also not an applicable diagnosis in the context of somebody having cultural restrictions around their eating. So if it's a culturally sanctioned practice, we don't want to label it as a disorder. But when we think about this big picture, right, that the ARFID presentation is really going to look like somebody who really struggles to diversify or expand their eating. They're generally not eating enough, and in some way, shape, or form, medically or psychosocially, it's impacting their life in a negative way. This often shows up early in life, but it can show up at any point in time. So we don't want to rule this out as just a pediatric disorder or just a kid's diagnosis. Anybody can be diagnosed with ARFID, and it can show up either with a longstanding history or a new acute onset. And then OSFED is the other big diagnostic category we have. So this other specified feeding or eating disorder category really captures many of these semi-defined eating disorder presentations that don't fit the other big buckets, but clearly cause distress, they cause impairment, and they're a significant problem for the individual experiencing them. So atypical anorexia nervosa is an individual who meets all the criteria for AN, but they haven't lost weight to a degree that it might fall below what a BMI chart might say is healthy or appropriate for them. Now, we know that anorexia is significant no matter what their body weight is and no matter how much weight somebody has lost. But when somebody is presenting in what looks like maybe an atypical body, the atypical anorexia nervosa diagnosis often is what is applied here. Subthreshold bulimia nervosa is really about the criteria for BN being met, but just not quite at the full frequency of a bulimia nervosa diagnosis. Again, reminding us that it doesn't matter that it meets a box, it's significant. If somebody's engaging in binge eating and compensatory behaviors, even if it's only once every 3 months, that is significant and we want them to get help. Same thing for subthreshold binge eating disorder. This is about the behaviors being there, just not at the frequency that the DSM requires. Purging disorder is purging in the absence of binge eating. So somebody who's engaging in a fairly typical day of eating, not reporting loss of control eating, not reporting binge episodes, but still engaging in purging behaviors after episodes of eating. Nighttime eating or night eating syndrome is when individuals are engaging in a significant amount of their caloric intake in the evening or at nighttime and not eating sufficiently during the day. It can have some binge type feels to what that eating looks like, but it is a different presentation than binge eating disorder. And then last would be orthorexia. And this one you might have heard about. This one tends to get a fair bit of media attention. It pops up in a headline every once in a while. But this is when an individual is presenting with almost an obsession around the quality, the purity, the organicness, the wholeness of their food. And as a result, has fairly restricted or limited intake due to this focus on needing to eat a very specific way. It's usually kind of a clean eating presentation or under the umbrella of it's really healthy, but it's healthy that takes a really scary turn for incredible restriction and nutritional limitation for folks. So when we think about screening and how do we begin to identify when someone is struggling with an eating disorder, there are lots of resources out there. I'm going to go through this really quickly because the goal here is simply to give you some direction on tools. There's no necessarily perfect tool that's going to capture anything and everything. The SCOFF is a great beginning 5-question assessment that you can work into intake packets or beginning screeners just to help identify, do I need to ask some more questions or not? We've linked the eating attitudes test, which is a 26-question pencil and paper measure at the bottom here. NITA has a screening tool. All of these tools can be implemented in a variety of ways to really help ensure that we are directing clients to the right resources and asking more questions when something tells us we need more. I always encourage folks to look at these assessments because sometimes we might know I need to ask more questions and I don't know the words to ask. So reading assessments, looking at how the questions can be worded can help give you confidence in using language for how might I ask somebody about their weight? How might I ask somebody about their behaviors? So some of these assessments can be great resources for helping you figure out what in the world do we even say when I want to ask somebody for more.
And if you are interested in tagging on to that and you're just curious, there in the medical provider resource that we've shared with you, there are some really great conversation starters because it can be really hard to start this conversation and you don't want to, you feel like you don't want to make a mistake and say something wrong. So we've given you some verbiage that you can use to kind of just jumpstart the conversation in addition to any of these if you have a concern.
Mm-hmm. And then when it comes time to make an intervention, it's always important for us to underscore the importance of jumping in. Act now. We want to act in a timely way to help somebody access resources as soon as possible. Individuals who are struggling with eating disorders may not always be able or ready to acknowledge that they're really ill, that they need more support. They may be really ambivalent about what treatment's going to involve. But we know eating disorders are deadly. We have one death every 52 minutes in the US as a result of an eating disorder, and they have the second highest mortality rate of any mental illness. We know that when we intervene early, folks have a greater chance of full recovery. And when we help folks access treatment, their mortality falls. To Simone's point about like, gosh, I don't know how to ask this question. I always encourage people to ask anyways, even if you feel like it's going to be clunky and you're going to say the wrong thing and you feel like you're going to offend them, because maybe you're the first person that's ever asked at all. And maybe they've just been waiting for one person to make it safe to talk about. So being the person that says, I want to know more can be really empowering for somebody who doesn't know how to seek help on their own and who's waiting for somebody to say, oh my gosh, what I'm going through is real and what I'm going through deserves attention. So asking something is better than staying silent and hoping that some other provider will. All right, Simone, back to you.
Okay, so these are the levels of care. So I will emphasize with this slide, and you can read the different levels of care. The important piece is that with eating disorders, there's always a multidisciplinary approach. So whether someone goes into a higher level of care to start and then gets discharged and steps down and goes into outpatient, or they start with outpatient and then have to get referred to a higher level of care, there's always going to be involvement from the primary care physician or the pediatrician, a therapist, a registered dietitian, sometimes a psychiatrist, always the support system of family and friends. And the emphasis on the OT, the occupational therapist, would definitely be engaged if there's someone who's struggling with ARFID, because again, we're working with sensory issues that they need to work through. As far as like when these are appropriate, we do have that guidance on our medical provider resource. And I see a question here that someone specifically is asking about when to refer to higher level, and I'll make sure that you have that. If not at the end during Q&A, I'll definitely follow up with a resource for you just so we can keep flying through the slides. Okay, this is another self-assessment tool that is really helpful. I'm going through, okay. To look at, again, how many food rules that come our way, which come our way all of the time in society, that we've adopted and that we also talk about with everybody, which also adds to the diet culture, the good, the bad, the right, the wrong, what we should and shouldn't do. So this is another tool that we highly encourage that you take for yourself. And then also if you're working with someone and you're interested in seeing their level of food rules and rigidity around what they'll consume and not, this is a great tool. Oh, okay. Um, am I doing this one? I'm doing this one. Okay, okay, so when we talk about nourishing our bodies, there's positive and then there's pathological nutrition. On the positive side, we're always going to look at its promoting health and adds to successful physical functioning. It includes nutritious foods, a desire to live a healthy life. My dog just chimed in. It allows for flexibility and enjoyment of food and social interaction and relationships. When it becomes pathological, it seeks health, but it begins to deteriorate and it will impair functioning. It is health seeking, but it excludes unacceptable foods or what someone will think is unacceptable. And it might be motivated by a need to self-soothe or cope and manage anxiety. And success will depend on adherence to those food rules, which again, why that self-assessment quiz is really helpful. A lot of times, folks, when they're getting into pathological nutrition, they're really beginning to have a feeling of fear and danger around food, and that's why they're wanting to control it. And it definitely adds to isolation and interferes with relationships. We know that eating disorders thrive in darkness and silence, and that's why we want to bring light to it. Definitely when it becomes pathological, we notice people kind of going in and not socializing. I think since this has multiple layers to it, whoops.
There we go. My slides were skipping around on me, Simone.
Okay. In the eating disorders field, we present with a non-diet approach, which includes regular eating, slowing down and savoring your food, allowing for pleasure, allowing for emotions. It's okay if you eat when you're sad and you eat when you're happy. There's really, again, it's not value laden. It's not like I'm good or bad because I ate when I was sad. We really want to emphasize the hunger and fullness cues and really trusting our bodies. The point that I'll make with that is we are born with these cues. We are born knowing how to eat when we're hungry and stop when we're full. And then society gets in the way, diet culture, all these food rules, and then we stop listening to that. So this non-diet approach says we're going to start really trusting our bodies because it tells us what it needs. So this was the slide. Let's just skip to the next one and then they will read this after you get through every single one. Okay. This pendulum swing is important because on one side is restriction and on the other side is binging. And what we know is that if there's going to be a restriction, there's usually going to be an equal and opposite binge at some point. Because again, like Sarah was talking about at the beginning, our bodies want to get back to its set point and it's where it's happiest being. We know that intuitive eating, and I don't know how much time I'll be able to spend on this, but intuitive eating is kind of like the unicorn in the room. Sure, we're always going to trust our bodies, but sometimes that's hard to follow. So we're going to use a little bit of the positive nutrition education, which is what we're talking about now. We're going to add in pleasure and emotion and, whether it's holidays, whatever it may be, we're going to add all that in and we're going to know that that box is kind of like the sweet spot and that pure 100% intuitive eating is hard. I'll also say that the diet culture has kind of hijacked intuitive eating and turned it into a diet. Please just know that we're not saying that. We're saying we just, again, want to trust our hunger and fullness cues. Okay, so in the same frame with what's positive and pathological nutrition, we also have healthy movement and exercise, and then exercise and movement that might not be super healthy. When it's healthy, we do want to challenge ourselves. We want to have a variety of activities that are enjoyable and energizing. We want to balance that with rest. That's an important piece. We want to be okay if we miss a workout, if it's raining or we have an injury. And there's flexibility around it and we can be adaptable. So while exercise is a very important part of life, and it can be for many people, it's not the central part of life when it's in that healthy range. It becomes concerning when it's used specifically to alter appearance. It becomes concerning. Again, there's that self-soothing we were talking about. When it's regulating discomfort or only used for that, yes, it can be helpful as a stress management tool, but there's got to be other things in the mix of self-care to help us get through that. And it's concerning when it's the central part of our lives and we distress when we can't work out and we become really rigid or closed-minded about it. And it becomes concerning when we become obsessive over those numbers. And again, back to that living in the darkness, when we train secretly, that's a flag. Exercise becomes a problem by the DSM-5. This is the diagnosis when it significantly interferes with important activities, occurs at inappropriate times or inappropriate settings, or when the individual continues to exercise despite injury or other medical complications.
Excellent. So we've talked about nutrition, we've talked about exercise, let's talk about body image. So body image also exists on this spectrum with lots of influences on it, right? We have cultural influences on how we think about bodies. We've got genetic influences on bodies that show up in how we think about them. We have societal influences on how we think about and how we view bodies. And this results in a wide range of how people end up feeling about their bodies. So we've got positive and negative body image on here. And when we think about positive body image, we think about people who are really in touch with their shape accurately. I can look in the mirror and have a pretty accurate idea of what I look like and how I take up space in the world. I can celebrate and appreciate the shape of my body. I can hold a belief that says my physical appearance does not necessarily define my character or my values. I can be proud and accepting of my body uniquely as it is. I don't spend a lot of time worrying about food, exercise, my body, and in general can feel confident and comfortable in my body, right? So when we think about positive body image, those are all the things we think about. We contrast that with this idea of negative body image, where we might experience distortion in how we perceive our size and shape, right? How we actually take up space in the world is maybe not what we see when we look in the mirror. There's more comparison of my body to somebody else's in a negative body image space, stronger beliefs that size and shape are important in indicating my worth as a person, increased feelings of shame, awkwardness, and anxiety about my body and how it, again, exists in the world, more obsessional thinking about food, exercise, and body, and stronger beliefs that your size or shape has some sort of indication on your success or failure as a person. And again, body image exists on a continuum between these things. I think it's always important to highlight too that positive body image does not mean that you have to wake up every day and sing like an I look awesome and love everything about myself right now chorus. Positive body image can be a space where maybe you don't love how your pants fit on that day. And cool, you wear them anyways, and it doesn't say anything about you, and you're still an amazing person, even if you don't love how your jeans are fitting you in this moment. And so again, it gets at this idea that it's really more about how we believe in that relationship between our physical appearance and who we are as a person. Our ability to be confident and comfortable no matter what our body is doing in any given moment, versus on that negative body image side where our worth is really tied to that shape and size experience. Time check here. What do we think, Simone?
I think we have to skip it.
That's what I thought too. Okay, so this video, we're going to assign you guys as homework. In addition to your 2 assessments, you're also going to watch a video. We've given you like 15 minutes of things to do. But this video is a really cool way to help think about size diversity. The real point of this video is to think about what happens when we assume that everybody should look the same. What happens when we stop embracing and appreciating diversity of bodies and sizes? A little bit of humor, a little bit of fun ways to think about it, but it really gets at this point of bodies are supposed to be different. They're supposed to function differently. They need different things. And if we try to make that not the case, we cause lots of problems. When we think about how to improve body image, there are lots of things we can do for ourselves and for others around us to help move people on the spectrum into a more positive body image space. So one is really working to avoid comparisons, right? Not comparing our size to other people's size, not comparing our shape, not comparing weights and numbers, not comparing how we eat, right? Avoiding comparisons and just letting ourselves exist as we are is huge. Related to that, decreasing that negative self-talk, being able to recognize and stop that negative talk track in our head that can relate to comparisons and then relates to the negative things we find about ourselves often as a result of those comparisons. When we think about media, right, which we are, for better or worse, exposed to all the time, thinking about what am I exposing myself to that makes me feel worse about my body? Is my Instagram or my TikTok feed or whatever other thing I consume full of people telling me what I should eat today and what diet I should go on and how I should get my body ready for a bathing suit this summer and just making me feel crummy? Let's not watch it. Let's find something else, right? So notice how media intake contributes to this idea that you should feel negative or that you're not good enough because of how your body looks. We want to work on cultivating the ability to appreciate your body, how it functions, what it does for you, how it helps you move in the world, beyond what it says about you and your worth. We want to engage in behaviors and spend time with people that make us feel good about ourselves, people that don't engage in comparisons, people that don't engage in negative self-talk, people that support thinking about bodies differently and make us feel good for more than just our body, right? For all the wonderful things about ourselves. We want to challenge diet culture altogether. We talked a little bit about that earlier, right? So challenging dieting behaviors, not giving into some of the marketing that we're all subject to about what we should do and change now. We want to wear comfy clothing, right? Wear what fits, wear what feels good, wear what helps you really enjoy being in the body that you have versus creating more beliefs around negativity or things that should change. We want to avoid the scale, right? If we don't need to know our weight, we don't need to know our weight, right? There are very few times when it's really necessary, right? Maybe some medication dosing, maybe some medical procedures, but otherwise, it's just another number that doesn't really change a whole lot. So noticing if you are drawn towards more weighing behaviors and doing what you can to avoid weighing yourself. And then limiting talk about weights, clothing sizes, and other numbers. We'll talk in a minute about like the importance of language. I'll go ahead and jump there now. When we think about language, it really does matter. When we think about the numbers that we talk about or the words that we use. So when we think about how to frame our language related to body image, we want to avoid placing shame, blame, guilt, or exerting any bribery around what people need to be doing. When we think about addressing eating disorders in general, we want to avoid offering simple solutions, right? It's not as simple as, well, just feel better about yourself or just eat a sandwich, right? There are no simple solutions for eating disorders, for changing these complex things that underlie what we're struggling with. We don't want to invalidate the experience that somebody with an eating disorder is having or try to convince them that something else is true. We also don't want to give advice about weight, exercise, or appearance, right? It's not going to be helpful just to tell them what we think should be different. We also don't want to ignore or avoid signs of eating disorders until it is severe and life-threatening. We talked earlier about the importance of early intervention. Early intervention is one of the things that we know helps promote full recovery. And so jumping on early warning signs versus ignoring it until the last minute is critical. We also really want to avoid, again, back to even body image language, we want to avoid putting food into categories like good and bad or healthy and unhealthy, right? Food is food. Carrots and carrot cake are all the same. So we want to make sure that we're not creating these false categories that can fuel more eating disorder type thoughts. And we also don't want to engage in diets, particularly if we know we're around other people who are struggling with their relationship with food. If we can model more balanced eating and not give in to that diet culture and not model the idea of restriction being necessary, that's hugely helpful. We do want to learn as much as we can, educate yourself. We want to listen, we want to validate, we want to model positive body image language, model balanced eating. We want to be honest and vocal about our concerns if somebody is struggling. We want to experiment with food, right? Having people in your life, your kids, your family members, whoever it is, seeing you try new things, experiment with food, try new recipes, right? It gets back to the fun of food and the ability to honor what our bodies want. We want to encourage self-responsibility and allowing people to have an active part in what their treatment and recovery will look like. We want to ask people how we can support them, and we want to help them get resources. We want to help connect them to care. Again, things that we want to make sure folks understand when we think about how to talk about eating disorders, how to talk about recovery, how to talk about all these things we've been going through. We want to watch out for appearance ideals. We want to not perpetuate any stereotypes as we're trying to help move people toward health and recovery. We don't want to play the numbers game. We don't want to give tips. We don't want to talk about numbers, right? If it's a number, we probably don't need to be talking about it. It's probably not helpful. And ultimately, we want to emphasize the seriousness of eating disorders and also not portray it as hopeless. It can be really, really serious and really, really scary. And hope can be there that it can change and things can get better. And helping people hear both, this is really, really, really serious. And you totally can do this, is the message we want people to walk away with. So when we think about what to do, I already said earlier, if you are thinking at all that there's a problem, say something. It is important to speak up and encourage folks to take that step to get help. It can be anybody. We already mentioned that a lot of doctors don't get a ton of training in eating disorders, so it's also helpful when you can point someone towards an eating disorder specialist, someone who you know will ask the right questions, who can help connect them to care. That can be a lot of people. The Carolina Resource Center for Eating Disorders is one of those options, and Simone will tell you a little bit more just about the services and supports available. But at the end of the day, say something and help them find their next connection point, whatever that might be.
And that gets us to CRC for ED. So we are the only nonprofit in the state that does this work. We provide education, resources, and support to individuals, families, and professionals concerned with disordered eating and recovery from eating disorders. So if we go to the next slide, this was just kind of like an overview, which you'll see this on our website. We do community education, just like we're doing right now. We do a lot of professional development. We have our annual conference every October. Our resources, we have our helpline, which kind of teeters over to the support bucket, but we have our helpline, we have a lending library, and we're just like, we keep our finger on the pulse of all things eating disorders so we can help connect folks. And it's not just connecting individuals and families, we also connect providers. So if you are a nutritionist and you want to connect with a specialist, an eating disorder specialist, or an ED informed provider, you can reach out to us and we can make those connections. We have our free virtual support groups every Wednesday. I know NAMI has a lot of wonderful support groups. If you're looking specifically for eating disorders, we're your people. Right now, we're doing free independent clinical assessments with our programming. We do a lot of advocacy, and we probably do way too much. But it's important that we have this resource and that you know where to go, whether it's for you or pointing somebody else in the direction of, hey, I don't know where to start. Well, you can start with CRC and we'll help get you started, connecting you with providers, whether it's outpatient or higher level of care or any other resources. There are a lot of other wonderful nonprofits in the country that have other programming that we might refer to. But basically, if you want to receive support or you want to provide support, this is our information here. And we're happy to answer any questions that you have. And Sarah, it's 12:50 exactly.
Look at us go.
So now we're going to open the floor for Q&A. And Sarah, do you see the Q&A box?
I will pull it up. I'm going to stop screen sharing so that I can see
Okay.
more here. There were some questions in the chat. I know that was answered as well, but y'all will get these materials, so you will have access to all of this information. Let me find the Q&A.
There was one that was asking about when to
Yeah.
refer for higher level of care, which if you feel like you want to touch on that, but I can also
Mhm.
follow up. And then there was another one that I think is a perfect question for you to answer
Yeah.
about someone who doesn't think they need it.
Yeah, so I'm going to go through the two questions that I see, and then folks can ask whatever they feel like they need to. So one question was around clients who are refusing a higher level of care but are showing medical necessity. Does this warrant IVC? And wow, that's a complicated question. And yes, it could. And so I think for us, I'm always thinking about the client's ability to truly understand the level of risk they're facing. There are some situations where a client may very clearly understand the medical risk that they're in and the risk that could come from not receiving care and be completely in a very clear state of mind about that and still not want care. One of the things that is important to note about most eating disorder diagnoses, particularly anorexia nervosa, is that it's what we call an egosyntonic illness. Um, the more you are in the disorder, the more reassuring and comforting it feels. It feels better to be in the disorder. Whereas if you compare it to somebody who is struggling with depression, it does not feel good to be depressed, right? Most individuals find their depression to be really like uncomfortable to sit with. They would like to feel better. The steps that they can take start to feel better by actively engaging in treatment. Whereas for individuals, again, with anorexia specifically, but many eating disorders, treatment itself feels terrible. It doesn't feel better right away. It actually feels a lot worse before it feels better. And so again, for some of our clients, they may say, no, I know exactly how sick I am. And I'm not willing to do the things that come next. That's going to be a hard situation to determine from an IVC standpoint. So I always recommend getting my psychiatrist friends and my medical doctor friends involved to make sure that we truly, truly can assess their understanding of the medical risk that they're in. But there are times when they are able to make that choice. They are very clearly aware of the medical risk, and that is devastating and it's really sad. And we hold hope and keep, holding out an open hand until they change their mind. There are other times when somebody maybe doesn't fully understand the level of risk they're in. They don't understand what might happen by not getting care. And so, again, in those moments, maybe there is an ability to move down that IVC pathway because we don't believe that they're able to make a decision that's kind of with clear mind and fully understanding what's happening. So it's not a very black and white answer. I'm sorry for that. But that just goes to show kind of the nuances of being in this field. But my psychiatrist friends are usually who I'm going to go to consult on any case like that to make sure that we don't miss what might be going on. Second question was related to level of care is working an outpatient and wanting to know more about how do you even determine an appropriate level of care for clients, such as when to refer to residential, when to refer to intensive outpatient, and all the other steps in between. I think about this in a couple different ways. A resource that I would suggest folks go look at, it's super dense, but the eating disorder section is not terrible. The American Psychiatric Association treatment guidelines has a best practices for the care of eating disorders that does a really nice job talking through level of care risk factors and determinations for eating disorders. I think for me, I'm always thinking about a couple of really key level of care decision making points. One is medical stability. If a client comes in and tells me they are motivated left, right, upside down, sideways, and all the way till Sunday, and their heart rate's really low, they're rapidly losing weight, they're really dizzy, they may not have a lot of choice about the level of care they're going to end up in because medical risk trumps everything. So medical risk is the first thing I want to make sure we're always assessing. Ability to change or level of support needed to change is another big one. Somebody who says, yeah, I'm super motivated, but I live alone and I really struggle to hold myself accountable. And I couldn't tell you the last time I convinced myself to eat breakfast, and I don't know if I'm ever going to be able to, might really struggle in outpatient compared to somebody that has a parent or a roommate or a partner who's able to help with accountability. So I look at what amount of support and structure does somebody need to make the changes that are necessary at this point in their illness, and can that work in the level of care they're in, or do we need to go up or down? And then motivation is another one, right? Someone might be medically stable, have all the supports in the world, and telling you, yeah, I am all in, let's do it. Or they might be saying, I don't know, like, I think you're kind of crazy. This sounds like a terrible plan. I don't know if I can do that. Their motivation will impact their ability to then access the resources in front of them and keep themselves stable. So those are three of the ones that I often pivot around most, and trying to make my initial kind of determination of, gosh, where do you need to be based on those things? But there's a whole table in the Psychiatric Association guidelines that fleshes out several other things that you could consider. Go ahead, Simone.
Yeah, and then in our medical provider resource, you'll also see the labs that we recommend that you
Hmm.
get. They're very specific. So sure, you can go to the doctor and get a bunch of labs, and we're asking that when we're really concerned that you look at those and utilize those. And then also because as a result of probably COVID, but we also understand that a lot of people don't want to leave their lives to go get treatment. It's very difficult to just stop everything and go. So
Hmm.
we're really grateful that there are some virtual options now. Some of the treatment centers are strictly virtual. It depends again on level of care, but there are more options now so that they don't have to completely disengage. And a lot of times with families, what we'll find is, especially if they're kiddos at college or whatever, like, oh my goodness, what am I going to do about college? Well, what we like to say, well, I like to say is, if it was cancer, you would stop and
Hmm.
you would treat the cancer. And we really want you to think about it in those terms because this is life-threatening and it can't wait. So I don't mean to be shocking, but it is really important that sometimes, disengaging from life and going into treatment is the best thing that can happen because you do that treatment and then you come back to life with your tools.
Hmm.
So I do think, and then the other thing I was going to add in when people are resisting, I think it's like with any maladaptive behavior, whether you engage in substance abuse or um, shopping or sex or whatever it may be, whenever we engage in a maladaptive behavior, we're doing it because it's making us feel better. So anytime that you're going to try to take that away, it's going to be hard for that person. So our goal and through treatment is making sure that we're replacing that with other choices that they can pull out of their toolbox, and that the food isn't the first thing to go to because it's our physical body. It's really easy to control it and it's really easy to go there, but it's a slippery slope. So we want
Hmm.
to make sure that we're engaging in other self-soothing behaviors to make us feel better.
Hmm. I'm going to answer two more questions from the chat, and then I see a couple of hand raised if folks want to ask their questions. So one question was, I think that certain antipsychotics, sometimes used to treat a mental illness, sometimes seem to trigger EDs. Is this possible? Not a psychiatrist, not a doctor, not a psychopharmacologist. I think what we do often hear folks complain about in a report is that some of the medications that can cause weight gain can then be followed up with body image distress. There may be some eating behaviors that emerge as a result of some of the medications. I wouldn't say that the medication itself like turns the eating disorder on, but it may change and activate other things that then kind of set off that eating disorder pathway, right? So if somebody was already predisposed to maybe some body image distress, maybe they already had some other experiences around weight, shape, and size, and now they're in a larger body that they don't feel like they're able to cope with, that can set up a cascade of potentially new behaviors, right? This idea of maladaptive coping. So I would, keep an eye out for patients who are experiencing body changes and how they're coping with that and how they're talking about their body as you're evaluating medication response. Go ahead, Simone.
And just to quickly add to that, if you know someone has disordered eating behaviors or a history of eating disorder, really encouraging when they
Mhm.
do go to the doctor. I mean, all doctors should screen for eating disorders, in my opinion, but
Yes.
really saying before any medication is administered, I need to tell you that I have a history of eating disorders. They need to know that so that then they can adapt maybe to a different medication that may impact hunger and fullness.
Mhm. Mhm. And then another comment about working with a student that doesn't want to leave school for treatment. So I think that's a really, really common one. It's a really hard one. So to Simone's point, there are lots of really great virtual treatment options out there, right? Lots of ways that folks can participate in virtual, IOP or PHP with little to minimal impact on school. And sometimes it's not possible to completely avoid disrupting school. And so I've had great luck working with other universities in the past at helping students access some sort of medical underload, some medical exemptions, ways that they can, make as much space in their life for treatment and school before we have to take that step of fully pulling out of school. But I think I would work on both angles with the student. How do we access the convenient forms of treatment, but also how do we really look at where school is in your life and create space for treatment? Because we may get to a point where it's not possible to just wait until you're not in school, and we can get creative while we're on the way.
And when somebody does leave school and returns when they discharge, the treatment centers are supposed to support with discharge planning and creating it, the transition back and making it safe and engaging with the counseling department at school and then
Mhm.
the family and just making sure that return to, life goes smoothly instead of just discharging back with no supports. And again, if there's not a team in place, we're happy to help you find those people. That's what we're here for. But yes, definitely advocating if you do have higher level of care when that the discharge plan includes reentry.
Yeah.
We did
We're at 1 o'clock on the nose.
So I want to thank you both so much for coming. We really appreciate your expertise and your just really supportive take on this topic and how, nuanced and thorough you were. I think this is one of the most misunderstood categories of mental illness, especially as it's been, almost glamorized in pop culture for decades. And to have a better understanding of all of the different facets of these disorders is so incredibly important for anybody working in mental health. So thank you very much. We appreciate you guys coming. Um, you will receive your resources, your recording, all of this information in your inbox by the end of the day tomorrow. I put that on my list. It is going to be done. And anything else that the speakers decide that they'd like to share, you will receive all of that. Also, we just want to encourage everybody to take an eye out. We've actually got another episode coming up next week on Thursday, March 5th. That one is going to be about youth mental health and how it can be impacted by the constant onslaught of negative news, especially as it's shared around social media. So please take an eye out for that. Please feel free to register for that one. Before we close up, any final words from our speakers today?
Just thank you for giving us the space to engage with your community and and for collaborating with us. I think collaboration is vital. So thank you so much, Amy, for all of your help, and thank you, Sarah, and thank you everyone for
The
coming.
ability to collaborate here.
Yeah, this has been great. Thank you so much. Keep an eye on our socials for other information about Eating Disorders Awareness Week. And of course, check out CRC for ED for more information. And I will make sure that somebody asked about the link for next week's episode. I can actually send that to anybody who registered if they have any interest. But until then, I hope everybody has a wonderful afternoon. Stay safe and warm. And we will see you at the next episode. So take care. Thank you.